A very good evening to all of you all. Welcome to Unacademy, where we can crack all NEET, which will help you all crack all NEET PG exams with us, with our top educators, quality content, and give you all a great learning experience. So, guys, let's crack NEET PG. A little about me. I'm Dr. Sasha Remedius. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesiology, and I have been working and teaching in Bangalore for the past 2.5 years. So today's topic is inhaled anesthetics part 3. I have covered this topic in 3 parts because it is a large topic, a very important topic. So inhaled anesthetics part 1, 2 and 3. I revised part 1 last time when I took part 2 class. So I will be revising part 2 right now before we proceed with part 3. This is a very important class, a little dry topic, but it's really important and will definitely, one of the questions among those 11 anesthesia questions will be from this topic, so you all need to be aware. So I've tried my best to break it down for you all to understand. So a little about Unacademy now. This is one of India's largest learning online platform, right? Where you get plus subscription, access to unlimited live and recorded courses, all from India's best educators. What do you get out of Unacademy? So we have our daily life classes where you are able to chat with your educator, engage in discussions with your educator, clear your doubts and answer polls, and all this is while the class is going on. So when you are at a coaching institute, it's very difficult for you to, first of all, the travel component for you to travel there. It consumes energy and time. And once you are there, it is one educator and so many students. It's difficult for the educator to clear everyone's doubts. It's difficult for students to get an optimal view, optimal audio component. So there are a lot of technical difficulties. Whereas over here, as such, 95% of the time all this is covered, right? And your doubts will be cleared, and all this is while the class is going on, as we have different platforms, and on the various platforms we have, you all can text us your doubts and we will always get back to you all with the answers. We have structured courses. All our courses are in line with the exam syllabus so that it helps you best prepare for the exam. Of course, we have our live tests and quizzes which will evaluate your preparation, with our regular mock. Like yesterday I had a test, and tomorrow again at 8:30 a.m. I have a half an hour quick test for you all, which you all can quickly. I mixed 2 topics, the previous 2 topics which I've taken a quiz on. I kept aside a few questions which I could mix, and so that you all can, otherwise just doing about the topic a quiz, you all can prepare and come for the topic. So I'll mix the few questions and let's see how you all perform. So you all will have unlimited access. So it's a one-time subscription, and you have access to all our live and recorded courses, and all this is to watch from the comfort of your device, your home. So wherever you are, whether you all are traveling, whether you all are in your hostels, or wherever you all are, from the comfort of your device, be it a phone, be it an iPad, be it a tablet. So from the comfort of your device, you all can access these classes and have a good learning experience. These are some of our top educators: Dr. Nikita Nanvani, Dr. Mohammad Azam, Dr. Divesh Mishra, and Dr. Preeti Sharma. Dr. Nikita Nanvani is a PG mentor for radiology as well as mnemonics, and she encompasses almost all the subjects. These are the courses offered. As you can see, there are 19 subjects. So yeah, I know NEET PG is not easy. You'll have to cover all those MBBS topics, those vast topics, right? It's not very easy. So each course, each subject, as you can see, has various courses offered, and of course it's not easy, but we are here to help you all, and it's not impossible, definitely. These are some of the ongoing courses on our platform. As you can see, course on neurophysiology, GI surgery, cardiovascular thoracic surgery, a capsule on the larynx, respiratory system, then courses on pathology. These are the various courses that are offered on the platform. Then coming to the subscription. So now this is the most important part of the because you'll need to understand why you'll need to subscribe and how important and beneficial these subscriptions are, right? So as you can see on the screen, there are 5 types of subscriptions. Now, I would not recommend that you'll really go for the 1, 3 and the 6 month subscription. These three, they are not very highly recommended, because it is not, like I said, it's a difficult exam. 19 subjects, to clear all those 19 subjects, it's not easy, right? I know it's not easy. And of course, it's not impossible. Definitely y'all can do it, nobody's saying it's impossible, but it's not easy, and you don't need to get stressed about it. Take one year off, take 2 years off, 12 months, 24 months, that is. Prepare, there is no harm. It is knowledge you're gaining at the end of the day, so there is no harm. Prepare, take your time, do it calmly, do it you'll be more focused, less stressed. It will help you all overall, even when whichever subject you'll get, taking that subject, the depth of the knowledge of that subject will be more for you all, right? So 12-month subscription, like I said, it is more economical to the subscription, because these are one-time subscriptions. So you 1, 3 and 6 months, after that duration is over, you cannot come back and clear your doubts. You cannot take those quizzes. You cannot access the live classes. You cannot access the recorded classes. That's all gone for you all. You all will need to subscribe again if you all need to do all that. And come on, so you all have to pay all over again. So it's not very economical, right? But with this 12-month subscription, it's a one-time subscription. Then for the whole of the year, you can access the recorded classes, live classes, quizzes, clear your doubts, chat with your educators throughout the year. So I would recommend the 12 and the 24-month subscription. Use my code. This is my code SASHA, and you all can avail a 10% discount by using my code. So guys, hurry. Don't waste time. Subscribe, because we do a lot of classes on the subscription platform too. They're not the same classes that we do on YouTube and all that. So hurry, subscribe. Very interesting classes, and there's more in-depth preparation on the subscription platform, right? So hurry, subscribe. Let us help you all prepare and help you all crack the exam. So now the NEET PG subscription, like I said, the 24-month subscription, so that too is a really good subscription. Again, not everyone can clear in 12 months. Some need 24 months. There's nothing wrong in that. Like I said, take your time. It's your time, it's your money, it is your comfort, it is your stress level, your convenience. There is nothing wrong. It is knowledge at the end of the day. You will not lose out on anything by studying for 2 years. Trust me, at the end, in the long run, it will only benefit you. So take the 24-month or the 12-month subscription. Use my code, like you can see at the bottom of the screen, SASHA, and avail your 10% discount. So now we'll just revise yesterday's topic before coming to today's class. Okay. So yesterday's the last time's topic was inhalation anesthetics part 2. We'll just go through it in brief. So basically, we dealt with the pharmacokinetics and the pharmacodynamics. For those of you who missed this class, and the solubility in blood, this is a very important factor. The solubility in blood is determined by the physical property of an anesthetic called the blood gas partition coefficient, which is the concentration of the anesthetic in the blood to the concentration of the anesthetic in the gas. So a blood gas partition coefficient of 5 indicates that the anesthetic is 5 times more soluble in blood than in gas. So it will take longer time for equilibration. The PA, the partial alveolar pressure, will take longer to equilibrate with the inspired alveolar pressure, because the inhaled anesthetic is very soluble in blood, 5 times more soluble in blood than the gas. So first the arterial pressure has to equilibrate with the alveolar pressure. So the arterial pressure first has to equilibrate with the alveolar pressure, then only the alveolar pressure can equilibrate with the inspired anesthetic pressure, not concentration. Yeah. So that is because this blood gas, the blood gas coefficient is high and it has a higher solubility. So this is the ratio, that is when the anesthetic is in equilibrium with the two phases. So the most soluble in blood is your halothane. Has a high solubility. Then comes your isoflurane, sevoflurane, nitrous oxide, and desflurane. Desflurane is the least soluble in blood, hence quicker onset of action because the valvular partial pressure equilibrates quickly. Now coming to the mechanism of immobility. So immobility, so anesthesia consists of two parts, unconsciousness and immobility. So there are two parts, unconsciousness and immobility. Now both these have a different mechanism of action. This unconsciousness deals with hypnosis and amnesia, and immobility basically deals with your with the inability to respond to surgical stimuli. So the primary action mechanism for immobility is the action is primarily at the spinal cord, and also depression of the excitatory neurotransmitters like NMDA, as well as enhancement of inhibitory neurotransmitters such as GABA. However, GABA does not have much of a role. The spinal cord, the action of the spinal cord has more of a role in immobility. Now, basically, no inhalation anesthetic. This immobility is not brought about by a single group of receptors. Neither is it brought about by a action of many group of receptors, right? So it is a very complicated phenomenon. But many receptors like your opioid, alpha adrenergic receptors all contribute to immobility, but they are not synergistic. They do not act together. Now, glycine receptors are the major mediators of inhibitory neurotransmission in the spinal cord and mediate part of the immobility. So, the GABA and the glycine are the two inhibitory neurotransmitters which also participate in immobility. Now, coming to the mechanism of action, no specific receptor has been described, like I said. This is basically mechanism of unconsciousness and immobility. So basically it activates the GABA and the glycine receptors, which are inhibitory receptors, and the 5-HT3 and the twin potassium channel receptors. It antagonizes the NMDA receptors, which is an excitatory, of course it is an excitatory receptor, and it inhibits nicotinic acetylcholine receptors. So basically it blocks the excitatory postsynaptic currents of the nicotinic receptors, and it also blocks the voltage gated sodium channel. So it blocks, it antagonizes NMDA receptors, it inhibits nicotinic acetylcholine receptors. These are basically located at your neuromuscular junction. So over here so basically it potentiates, it inhibits the action of acetylcholine on these receptors, hence prevents muscle contraction. Hence it enhances the action of non-depolarizing muscle relaxants, and also it has action on the voltage gated sodium channels. So at clinically effective concentration, so by acting on the GABA receptor, it increases the sensitivity of GABA. Okay, it does not bind to the GABA receptor. It increases the sensitivity of GABA to the GABA receptor. Okay, and this increases the chloride influx, which causes hyperpolarization, which leads to decreased excitability and CNS depression. Basically, there will be no action potential generation, no muscle contraction, and will lead to CNS depression. Coming to the mechanism of unconsciousness, there will be loss of consciousness, that is, there will be loss of consciousness, that is hypnosis and amnesia. Like I said, there are two parts of anesthesia, that is your unconsciousness and your immobility. So the mechanism of unconsciousness basically is there will be loss of consciousness, that is hypnosis and amnesia, and like I said, response to skin incision is your immobility part of general anesthesia. Now the actions to produce of inhaled anesthetics to produce unconsciousness is via GABA and glycine receptor. The spinal cord does not have much action in producing unconsciousness. The spinal cord depression of the spinal cord plays a role in immobility. So inhibition of neurotransmitter release can inhibit synaptic transmission, hyperpolarization decrease the excitability, and this is mediated through also, like we discussed, right, the sodium channels in the previous slide, the sodium channels and also the voltage gated ion channels play a role. Now coming to stereoselectivity, so the most definitive evidence that general anesthetics act by binding directly to proteins and not a lipid bilayer comes from stereoselectivity. So basically there was this Mayer-Overton theory. Okay, this Mayer-Overton theory, which postulated that these inhaled anesthetics bind to lipids and bring about their mechanism of action. Okay, that was what was postulated by Mayer-Overton. But the stereoselectivity disproved this theory and said the most definitive evidence is they act by binding directly to proteins and not a lipid bilayer. Now, the levoisomer of isoflurane is more potent in enhancing potassium conductance, and hence it is better than the dextroisomer. So the inhibitory G protein and hyperpolarization produced by increased potassium conductance results in depression. So levoisomer has more potassium conductance, which results in depression of neuronal excitability. Now coming to the metabolism, I'll be dealing with the metabolism briefly. I mean, it's all mixed in today's class, so this is important. Metabolism is very important because a lot of questions can come from metabolism. It's a little confusing, but yeah, so that's why I'm repeating it, and I shall be dealing with it again in today's class when I'm dealing with the individual inhaled anesthetics. I know it's a little long class overall today. I'll be taking class till 9 p.m. today. So 1.5 hour class, but we'll go through it together, right? And it will be beneficial for you, I guarantee you. So metabolism, it is very small but important for two reasons. Okay, so the intermediary metabolites and end or breakdown products from exposure to carbon dioxide absorbance may be toxic to the kidney, liver, or reproductive organs, and the degree of metabolism may influence the rate of decrease of alveolar partial pressure. So basically the degree of metabolism influences the conclusion of anesthesia, and this is more for halothane and methoxyfluoride because these are the two drugs which undergo maximum metabolism. Okay, all the other the volatile anesthetics are basically most of them, the rest, the newer ones, the halide ones, are eliminated by the lungs exhalation, right? And they undergo very little metabolism. That is your sevoflurane, your isoflurane, your desflurane. Okay, so they eliminated by the lungs, and hence they undergo very little metabolism. But halothane and methoxyfluorine undergo a lot of metabolism, and this leads to your hepatic and renal effects of these drugs. Okay, so the intermediary metabolites, the breakdown products from exposure to carbon dioxide absorbance. So basically all these can react with the carbon dioxide absorbent. Any desiccated or breakdown products of their breakdown products can react with the carbon dioxide absorbents and can be toxic kidney, liver, as well as reproductive organs. So the assessment of metabolism is by two methods. One is by the measure of metabolites, and the other is a comparison of amount of anesthetic recovered from the exhaled gases with that taken up at administration. Now, basically, the measure of in the measure of metabolites, the mass theory is used, but it is not very effective. But these are the two ways of assessment of metabolism. Now, the determinants of metabolism are chemical structure, hepatic enzyme activity, blood concentrations of the anesthetics, and genetic factors. Coming to the chemical structure, so the ether bond and carbon halogen bond are the sites most susceptible to oxidative metabolism. Okay? And the two halogen atoms on the terminal carbon atom represent optimal arrangement for dehalogenation. When the terminal carbon has fluorine, it is fluorine atom, it is resistant to oxidative metabolism. A hepatic enzyme activity. The activity of hepatic cytochrome P450 enzymes responsible for metabolism may be increased by a variety of drugs, uh, including local anesthetics. So your basically your enzyme inducers like phenobarbital, phenytoin, and isoniazide may increase defluorination. And obesity increases defluorination of halothane and fluorine and isoflurane for reasons unknown. Now the blood concentration. The fraction of the anesthetic that is metabolized on passing through the liver is influenced by the blood concentration of the anesthetic. So disease states such as cirrhosis and all that decrease hepatic blood flow and hence drug delivery, and there will be prolonged action or by decreasing the amount of viable liver and available enzyme, they will increase the duration of action, decrease metabolism. Less soluble inhaled anesthetics, basically the rest, halothane is most soluble, so the rest, like I just showed, so the less soluble tend to be exhaled rapidly by the lungs, and less drug is available to pass through the liver, so they do not undergo that much of metabolism, and hence they are not that toxic to the liver and the kidney. Now, halothane and methoxyfluorine are more soluble in blood and lipids and are likely to be stored in tissues that act as a reservoir to maintain sub-anesthetic concentration. So, halothane and methoxyfluorine are more soluble in blood and lipids because it is highly soluble and stored in tissues, and this maintains the concentration gradient because from fat it will continuously maintain a concentration gradient for uptake. So even after anesthesia is stopped, they will be released from these tissues. Now coming to the metabolism of specific inhaled anesthetics, I won't be dealing with metabolism today. I will in the fresh class, I will be dealing to some extent with the side effects of the metabolism. So nitrous oxide 0.04 undergoes reductive metabolism to nitrogen in the GI tract. Anaerobic this is influenced by the anaerobic bacteria such as Pseudomonas, which is responsible for this. And whenever the oxygen concentration is more than 10% in the GI tract, an antibiotics presence of antibiotics, will inhibit the metabolism by anaerobic, metabolism by anaerobic bacteria. Okay, there is no evidence that nitrous oxide there is no metabolism in the liver. So halothane, 15 to 20% of halothane undergoes metabolism basically in the liver, and it undergoes oxidation and as well as reduction depending upon the amount of oxygen present. So when the PO2 decreases, it's reductive metabolism, and when the PO2 is at optimal levels, it is by oxidative metabolism, that is the cytochrome P450 enzymes. Now coming to the oxidative metabolism, trifluoroacetic acid, chloride and bromide are the metabolites. These are basically your metabolites of halothane. I'll be dealing with it again today. And in genetically susceptible patients, basically a trifluoroacetyl halide, which is an oxidative metabolite, may react with the microsomal proteins on the hepatocyte, and this causes a change to these proteins on the hepatocyte to become neoantigens, that is, they become foreign antigens to the body, which stimulate the formation of antibodies, leading to severe necrotic liver failure. So plasma concentration of bromide increases by 0.5. So bromide is another metabolite. The plasma concentration increases by 0.5 milliequivalents for every Mach hour. The signs of bromide toxicity do not occur until plasma levels reach more than 6 milliequivalents per hour, which remotely occurs. Okay, so this basically bromide toxicity produce, increased somnolence, confusion. So halothane anesthesia is more likely to be associated with intellectual impairment, which is attributed to bromide. The reductive metabolite is fluoride. Volatile products which may result from, it is a volatile product which may result from reaction with carbon dioxide absorbance. So increased plasma fluoride concentration reflects a reductive metabolism. The levels of plasma fluoride are far below the levels likely to produce nephrotoxicity. That is, fluoride induced nephrotoxicity. Data do not support a role for reductive mechanism in halothane hepatitis. Basically, that is your it is an oxidative mechanism causing halothane hepatitis. I'll be dealing with that in detail soon. Now, N-fluorine 3% undergoes oxidative metabolism by cytochrome P450 to form organic and inorganic fluoride compounds. Like halothane, adducts can be formed, which can cause formation of neoantigens. But so all enfluorine, isoflurane, desflurane, all can form, not sevoflurane, can form adducts like but basically those neoantigens. But because they are not metabolized that much, the primary route of metabolism is by the lungs. As a result, they do not produce hepatotoxicity. So like I said, even isoniazide can increase defluorination in genetically determined patients. So isoflurane, only 0.2% undergoes oxidative metabolism. These are the metabolites difluoromethanol and trifluoroacetic acid. Adducts are formed, but the primary route is by the lungs. Nephrotoxicity and hepatotoxicity are unlikely, and even in the presence of induction enzyme like isoniazid, fluoride concentrations are much less than that of fluorine. Now coming to desflurane, 0.02% undergoes oxidative metabolism. It has a very strong carbon fluorine bond and hence less metabolism. Adducts can be formed, but again no hepatotoxicity because primary route of elimination is by the lung. Even with isoniazide enzyme induction, fluoride is much less than N-fluorine as well as sevoflurane. These are the metabolites: inorganic fluoride, trifluoroacetic acid, carbon dioxide, and water. Carbon monoxide toxicity. This occurs with desflurane. It reflects degradation of the volatile anesthetic that contains carbon CHF2 moiety basically, and the strong bases which are present in desiccated carbon dioxide interact with this halide moiety. The factors that influence carbon dioxide production are the dryness of the carbon dioxide absorbent, high temperatures and increased carbon dioxide production, that is basically increased metabolism, and the high fresh gas flows and which cause dryness, and the type of absorbance. So this is the decreasing order of the inhaled anesthetics that likely to cause carbon monoxide poisoning. Highest is with desflurane, N-fluorine, and sevoflurane, but it only occurs when there is a reaction with desiccated carbon dioxide. Halothane and sevoflurane do not possess vinyl groups and hence no carbon monoxide production. Carbon monoxide formation with sevoflurane can still occur when an exothermic reaction between the volatile agent and desiccated carbon dioxide is happening. So all modern local volatile anesthetics can cause carbon monoxide release when they react with desiccated by carbon dioxide absorbance. So detection is difficult, and it is very difficult to detect because the only sign will be the decreased pulse oximeter readings. So normal is around 100%, that is your blood oxygen saturation. And with the carbon monoxide poisoning, basically the carboxyhemoglobin in the blood will cause the saturation to fall to about 92%. But of course, with erroneous gas analyzer readings, it is one can clinically say that maybe there is a chance that the carbon dioxide is desiccated. So erroneous gas analyzer readings is basically produced due to the metabolite trifluoromethane that is produced by N-fluorine, desflurane and isoflurane. So what happens is, even though you are using desflurane on the monitor, so the gas analyzer basically will project on the monitor the type of inhalation agent being used. So if you're using desflurane on the monitor, it will show sevoflurane. So sevoflurane undergoes oxidative metabolism by cytochrome P450 to form inorganic and organic fluoride compounds. Diabsorbent containing sodium or potassium hydroxide can react with SIVO and result in a breakdown product chloromethyl 2,2, that is difluoro 1 vinyl ether compound A, also known as compound A, which is nephrotoxic and hepatotoxic in animals. But there is no because sevoflurane does not undergo metabolism to acetyl halide, no hepatic effects. So the carbon dioxide absorber fires were produced with berry lime. That is why it has been stopped. It has been banned from the market. It is withdrawn from the market. So dry desiccated carbon dioxide absorbents produce carbon monoxide and flammable compounds like formaldehyde and methanol. The formaldehyde itself causes pulmonary injury. The reaction produces heat, which speeds up the breakdown of sevoflurane. Temperature further rises and there's further dryness and more strong bases are released, and there will be excessive heating up occurring in the absorber canister, which leads to fire. This can be clinically detected by a sudden decrease or delayed increase in inspired sevoflurane concentration when the vapor setting is set, vaporizer is set to a particular level. Okay, so that was the previous class. Now today's class will be part 3. Okay, now it will be basically a comparative pharmacology. We'll be comparing the various systems today. Okay, so as you can see, inhaled anesthetics, they are classified as volatile liquids and gas. The gas is nitrous oxide. The volatile liquids are ether, halothane, N-fluorane, isoflurane, desflurane and sevoflurane. Okay, now coming to the respiratory effects. So the respiratory, so this is just the respiratory effects are in general. I've written about each each anesthetic has been dealt with in this. I will tell you all the comparative pharmacology. And of course, in the following slides, it's a little different pattern. I'll explain to you all when we come to it. Don't worry about it, guys. Okay. So coming to the initial number 1, respiratory affects the pattern of breathing. So all the inhaled anesthetics except isoflurane produce an increase in the frequency of breathing. That is basically they increase the respiratory rate except isoflurane. So isoflurane does increase the respiratory rate up to 1 Mach, but after that no increase. There is no increase in the frequency of breathing. Okay, more than 1 Mach isoflurane increases more than 1. If it is more than 1 Mach, isoflurane, no, this is not isoflurane, I'm sorry, this is a mistake. At more than 1 Mach, nitrous oxide, I'm so sorry. At more than 1 Mach, nitrous oxide increases the frequency more than any other inhalation anesthetics. And also this mechanism, the mechanism of nitrous oxide to increase the frequency of breathing can be attributed to because it stimulates the pulmonary stretch receptor. So all the other anesthetics, including nitrous oxide, have some CNS effect, okay, but they have no effect on the pulmonary stretch receptors. But nitrous oxide has an effect on the pulmonary stretch receptors. But generally, we do not use more than 1 Mach of nitrous oxide because it can cause lot of hazardous effects as explained in my previous classes. So it can cause a lot of hypoxia and other hazardous effects of nitrous oxide. So we do not generally use more than 1 mAh, but more than 1 mAh nitrous oxide increases the frequency of breathing the most among all inhalation anesthetics. The mechanism of action is basically CNS effects, the stimulation of the central respiratory chemoreceptor neurons, basically the thick THIK1 receptors, which is a 2-pore potassium channel. Now remember, in the mechanism of action we studied that a 2-pore potassium channel is activated. So basically it brings about the respiratory effect of increased frequency of breathing. I just revised it with you all, right? So the stimulation of central respiratory chemoreceptor neurons, and in case of nitrous oxide also the effect of stimulates the pulmonary stretch receptors. Conversely, the tidal volume is decreased because of this rapid breathing, rapid respiratory rate. There will be a decrease in minute ventilation, and the PaCO2 increases because the minute ventilation is decreased. So basically minute ventilation is your tidal volume into respiratory rate. Both are decreased. So ventilation is basically being decreased. So there's an increase in your PaCO2, right? The net effect is rapid and shallow. The net effect is rapid and shallow breathing. So the ventilatory response to carbon dioxide, basically the ventilatory response to carbon dioxide, basically the PaCO2 is increased. So the the I'm sorry, the ventilatory response to carbon dioxide, basically when there is carbon dioxide there should be increased respiratory rate and washout of carbon dioxide, but this ventilatory response is decreased. It is abolished, decreased by inhaled anesthetics. So it is decreased by these inhaled anesthetics, and as a result the PaCO2 is increased. Okay. Nitrous oxide does not increase. Nitrous oxide does not increase PaCO2. So this is very dangerous in COPD patients, right? Already they already have, this is very dangerous in COPD patients. They already have a higher PaCO2 with this depression of the ventilatory response and ventilation. The PaCO2 increases further in these patients, which can lead to respiratory acidosis and arrest. So the nitrous oxide does not cause this increase in PaCO2, hence substitution of this anesthetic for a portion. So this nitrous oxide being added with the other volatile anesthetics would ideally result in less depression of ventilation, because that the dose of the other anesthetic is being reduced, so there will be less PaCO2 increase. Now surgical stimulation increases minute ventilation by 40%, but a decrease in PaCO2 is only 10%. Okay, so now whenever surgical stimulation is there, that is incision, minute ventilation will be increased by 40%, right? But the decrease in, so when the minute ventilation increases, ideally PaCO2 should be flushed out, but the decrease in PaCO2 is only 10%. So the decrease in PaCO2 is only 10%. So this is because of the activation of the sympathetic system. So the sympathetic system gets activated and there is excessive production of basically your catecholamines, which causes increased production of PaCO2. So this offsets the increase in minute ventilation, right? It is actually the rise in PaCO2 is much higher than the increase in minute ventilation. So the minute ventilation cannot compensate for the rise in the PaCO2. Basically, the minute ventilation cannot compensate because of the activation of sympathetic nervous system and release of catecholamines. It cannot compensate for increase in PaCO2 due to this sympathetic activation. Okay, now the mechanism of depression, the depressant effect is basically is an effect on the medullary ventilatory center, and there is basically loss of chest wall stabilization. Basically the intercostal muscles lose their elasticity, lose their strength, they become lax. So there is loss of chest wall stabilization as a result. During inspiration, when the diaphragm moves out downwards, there will be collapse of the chest wall inwards because there is loss of chest wall stabilization, and this will increase the functional residual capacity. All inhaled anesthetics depress the ventilatory response to hypoxemia. So the ventilatory response to carbon dioxide is also decreased. The ventilatory response to hypoxemia is also decreased, and sevoflurane is a, however, sevoflurane and isoflurane are the two useful bronchodilators. Now coming to the airway resistance and irritability. So the main factors, the important risk factors are young age, that is less than 10 years, uh, respiratory tract infection, COPD patients, and intubation. So tracheal intubations, especially in asthmatic patients around, can cause high amount of airway resistance and irritability. Sevoflurane and isoflurane produce bronchodilation and are hence very useful in asthmatics. However, isoflurane is pungent spelling, so it can trigger bronchospasm, and hence it cannot be used as a sole induction agent, whereas sevoflurane can be because it does not have any odor. Then upper airway reactivity is more suppressed by sevoflurane than desflurane at 1 max. So the upper airway reactivity is more suppressed by sevoflurane than desflurane at 1 max. So desflurane actually can cause bronchoconstriction too. It is a bronchodilator. But it can cause bronchoconstriction too. Okay, it can cause, but basically a bronchodilator. And the upper airway reactivity, this upper airway reactivity is basically assessed by the cough reflex. Seen by inflation So it is seen, the cough reflex that is seen by inflation of tracheal tube cuff, basically your endotracheal tube. Okay, so that is what upper airway reactivity. It is assessed by the cough reflex that is seen by inflation of tracheal tube cuff is suppressed more by sevoflurane than desflurane at 1 mac. So sevoflurane when exposed to desiccated carbon dioxide. So basically sevoflurane when it is exposed to desiccated carbon dioxide absorbance can produce toxic gases, especially formaldehyde. Okay, especially formaldehyde, which inhalation of which can increase airway irritation. So basically the respiratory effects, pattern of breathing, it just a quick revision. It increases the frequency of breathing. It decreases minute ventilation and tidal volume, and increases PaCO2 at more than 1 Mach. Nitrous oxide increases the frequency of the rate of respiratory rate more than any other inhaled anesthetic. Isoflurane is free of, it produces only a dose dependent increase in only up to 1 Mach. Beyond that, it has no effect on the respiratory rate. This increase in respiratory rate is brought about by action on the respiratory chemoreceptor neurons, that is your TIC1 receptor, which is a 2,4-potassium channel, right? Then the ventilatory response to carbon dioxide and hypoxemia is depressed. Nitrous oxide does not cause a change in PaCO2, and hence it can be used along with volatile anesthetics to reduce the increase in PaCO2. This can be useful in COPD patients. Now, surgical stimulation increases the minute ventilation, but the decrease in carbon dioxide is not proportionate because of the sympathetic stimulation that actually increases carbon dioxide out of proportion to the increased minute ventilation cannot compensate for this increase in carbon dioxide. The depressant effect is brought about by loss of chest wall stabilization and medullary ventilatory center depression. Airway resistance, of course. Isoflurane and sevoflurane are potent bronchodilators. However, sevoflurane can react with desiccated carbon dioxide and produce toxic gases like formaldehyde, which can cause airway irritation. And the upper airway reactivity tested by inflating the cough reflex, that is produced by inflating the tracheal cuff, is suppressed by sevoflurane more than desflurane at 1 Mach. Now coming to individual gases. Nitrous oxide. Physical property of nitrous oxide, also known as your laughing gas. It is also known as your laughing gas. It is not flammable. It is odorless, colorless, tasteless. So it is odorless, colorless, tasteless. The laughing gas, and it is not flammable. Pharmacology of nitrous oxide. It is a good analgesic, weak anesthetic. So it is a very good analgesic. Basically, it is used in short obstetric procedures. It is very useful. And it really decreases the MAC of the inhaled anesthetics. Hence, the concentration is decreased. As a result, lesser side effects. Okay. So when MAC is decreased, there is the potency gets increased. So lesser amount of the drug of the inhaled anesthetic needs to be used, and hence lesser side effects. It is a weak anesthetic. It cannot be used alone. It has to be supplemented with other inhalation agents because it has an additive action. It has a very high MAC of 104. As a result, high concentrations have to be set to achieve high concentrations have to be set to achieve induction, which is very dangerous. It is excreted via the lungs. MAC of 105%, like I said, 104. Low water solubility and not metabolized in the body. So it is not metabolized in the body and has a low water solubility. Now, side effects of nitrous oxide is it undergoes diffusion. This has been dealt with in my previous classes, but I will be talking about it again. So it produces diffusion hypoxia. So in a closed gas space, nitrous oxide diffuses 34 times faster. Okay. So I'm sorry, 20 times, correct. In a closed gas phase, nitrous oxide can diffuse 20 times faster than it can be removed, resulting in an expansion of. So basically, nitrous oxide is 34 times more soluble in blood than nitrogen. So it is 34 times more soluble in blood than nitrogen. As a result, this will diffuse rapidly. It will diffuse rapidly out of blood. Okay, anyways, it will diffuse rapidly out of blood and enter into your closed space and cause expansion. So basically, if it is a compliant space, it will expand like your bowel, like your pneumothorax and your bowel. And if it is a non-compliant space like your middle ear, there will be no expansion. The pressure within the cavity will rise. Basically, in middle ear surgeries, so basically the eustachian tube vents air out passively in a normal person. But during middle ear surgeries, the eustachian tube will be infected or compromised. As a result, whenever if not nitrous oxide is used, there can be a build-up of pressure within the closed space, leading to rupture of the eustachian tube. And nitrous oxide causes CVS depression. I'll come to that. And it is teratogenic. I will come to that too. So nitrous oxide causes diffusion hypoxia. What is diffusion hypoxia? So basically, when inhalation of nitrous oxide is discontinued abruptly. So when during that was, and then I'm explaining it here better. So when inhalation of nitrous oxide at the end of general anesthesia, when nitrous oxide is discontinued abruptly, there is reversal of partial pressure gradient such that nitrous oxide leaves the blood to enter alveoli. So it is 34 times more soluble in blood than nitrogen. Hence, it leaves the blood quickly to enter alveoli. This will dilute your PaO2 such that the partial alveolar oxygen pressure dilutes such that the arterial pressure decreases. There is also decrease in the alveolar CaO2, which decreases your stimulus to breathe further. So it's decreasing the alveolar O2 as well as the alveolar CO2. So when the alveolar CO2 decreases, there is a decreased stimulus to breathe. And it is directly diluting the alveolar PaO2 and hence decreasing the arterial O2. Hence, it is common practice to prevent this. It is common practice to first fill the lungs with oxygen. So the oxygen concentration, so if both are kept at 2 liter flow, the oxygen concentration should be increased initially towards the end of anesthesia. And after maybe about 2-3 minutes, that's when the nitrous oxide should be turned off so that the lung is filled with oxygen, and this will prevent the hypoxemia. Now the second gas effect, so the ability of large volume uptake of the, so when nitrous oxide, oxygen and a volatile anesthetic are mixed, the ability of a large volume uptake of one gas, that is your nitrous oxide, the large volume uptake of this gas accelerates the rate of rise of your other two gases in the flow space of the, so it accelerates the rate of rise of alveolar pressure of a concurrently administered companion gas. So this is your second gas. So because it's a closed, the lung is a closed space, basically this is diffusion hypoxia. Your lung is a closed space. So your lung is basically a closed space. So when nitrous oxide, the first gas, increased, uh, there is large uptake of it by the blood because it is very soluble in blood. So large uptake in the blood. So within the small space of the lung, there will be concentration of the oxygen and the inhalation agent. And to fill the void, because there is so much of nitrous oxide that has been taken up by blood, there is the tracheal inflow is increased to fill that void. So the second gas effect depends on the concentrating effect. Basically, it depends on a concentration effect. That is what the second gas is doing, which depends on your concentrating effect. Concentrating effect, and also depends on your tracheal inflow. Okay. So these are the two factors which affect the concentration effect. Concentrating effect, I just told you about it being the gases being concentrated in the closed lung volume, and tracheal inflow to fill up that void that is produced by uptake. So this is your basically the diffusion hypoxia, your uh, second gas effect. Basically, this is the effect in closed gas spaces. So nitrous oxide diffuses quickly. It is more 35 times more soluble, so diffuse quickly outside in an inner pneumothorax. It can enter the pleura and lead up to a tension pneumothorax, causing a threefold size increase in size. Now coming to the central nervous system, central CNS effects of nitrous oxide. So the CNS effects of nitrous oxide, there is slower frequency and higher voltage on EEG as dose is increased. So the normal effect on of volatile anesthetics in concentration, all volatile anesthetics less than at concentrations of less than 0.4 Mac, there will be an increased frequency and voltage on EEG. Okay, as on the EEG, there will be increased frequency and voltage. As the MAC increases to more than 0.4, basically this, so initially this increased frequency and voltage is known as an excitement phase. There will be some excitement initially. Okay, when you're inducing a patient, the initial when, see, 0.4 MAC is usually, more than 0.4 MAC is usually used once the patient is fully under. So to take the patient under, to sedate the patient, generally 0.4 MAC will be used. There will be increased frequency and voltage on the EEG, which clinically is seen as the excitement phase. Okay, now at more than 0.4 MAC, basically the cerebral metabolic rate of oxygen also come down. The CMRO2, the cerebral metabolic rate of oxygen, also the metabolism of the cerebral metabolic rate of oxygen requirements comes down because metabolism is less. As a result, there will be a decrease in frequency. You will see a decrease in frequency and a continued with an increase in the voltage will remain this, will increase, and the frequency will decrease. With isoflurane, of course, burst suppressions are seen on EEG, but not with any other inhaled anesthetic. Isoflurane reduces burst suppressions on EEG. Okay, so with nitrous oxide, it may increase motor activity with clonus and opisthotonus. Higher MAC is needed to prevent awareness, and hence it is not so effective. The MAC is very high to prevent awareness, hence using nitrous oxide alone is not so effective. It increases the cerebral blood flow, but due to it increases the cerebral blood flow, that but that's at more than 1 mac. So the cerebral blood flow is generally increased at more than 1 mac, but because of its high mac, uh, to reach this 1 mac, a very high concentration needs to be used, which is generally not used because of the side effects. So the increase in cerebral blood flow is generally not seen because isoflurane concentrations are usually less than 1 mac. Now coming to the CVS effects, so there is no change or modest increase in SBP. Nitrous oxide causes an increase in SBP. All other inhalation anesthetics generally decrease the BP, but nitrous oxide produces no change or a modest increase in SBP. The myocardial, so all the inhalation anesthetics except this have myocardial depressant effects, but the depressant effects of nitrous oxide are offset by the mild sympathomimetic effect. So it has a sympathomimetic component, and this offsets the myocardial depression. So you will not see a decrease in BP, and a decrease in heart rate will not be seen. So there is increased right atrial pressure, which reflects the increased pulmonary vascular resistance due to the sympathomimetic effect. So the sympathomimetic effect is seen due to activation of the brain nuclei that regulate beta adrenergic outflow. So the mechanism for this sympathomimetic effect is basically activation of the brain nuclei that regulate. So there is beta adrenergic outflow. There is increased beta adrenergic. There is increased beta adrenergic outflow, as well as there's inhibition of uptake of norepinephrine. So there's increased catecholamines. As a result, there will be increased sympathomimetic effects. These sympathomimetic effects offset the myocardial depression, and they also lead to pulmonary vascular pressure rise. So there will be increased pulmonary vascular resistance, which will lead to the right heart atrial increased right atrial pressures. There is no change in systemic vascular resistance. Isoflurane and except halothane causes decrease in myocardial contractility and cardiac output. No effect on systemic vascular resistance. All others decrease systemic vascular resistance. There's no change on systemic vascular resistance, and it leads to also causes constriction of cutaneous blood vessels, is of course seen because of its sympathomimetic vasoconstriction. So at doses more than 1 mac, it can produce skeletal muscle rigidity. Okay, so it can produce skeletal muscle rigidity at doses more than 1 mac. It does not alter uterine contractility. So now in obstetric patients, all other anesthetics cause uterine atony, they cause uterine relaxation. As a result, nitrous oxide can be substituted with other volatile agents to counteract the uterine atony that is produced by the other agents. It causes a dose dependent of inhibition of leukocytes and chemostaxis, basically again migration. Exposure that is lasting for 4 days or longer causes agranulocytosis. So prolonged exposure can cause agranulocytosis. It interferes with the activity of vitamin B12 enzymes, which are essential for DNA synthesis and erythrocyte formation. So basically it interferes with methionine synthase, which is very important for conversion of heme to methionine. Methionine is basically required for neuronal functioning, and hence that will not happen. And also thymidylate synthase, the other vitamin B12 dependent enzyme which is required for DNA synthesis, is also inhibited because vitamin B12 will not be available. As a result, DNA synthesis is also inhibited and methionine synthesis is inhibited. This will result in sensorimotor neuropathy with signs of posterolateral spinal cord degeneration too. This mimics pernicious anemia. These points are very important, guys. The MCQ can be asked, mostly will be asked along these lines. Coming to ether, not in use right now, just a to know. It is colorless, highly volatile, pungent, flammable. That is why it was stopped. Pungent, and explosive stored in cool areas. Solubility is 12, MAC is 2 to 3%. Pharmacodynamics. Lungs stimulate respiration, and in the lungs it stimulates respiration, causes increased secretions, not good in respiratory diseases because of the increased respiration. Kidney, it decreases urine output. Liver, it has minimum effects and decreases liver glycogen. Heart, there's an initial increase in cardiac output, then decreases cardiac output and suppresses the vasomotor center. So in the heart, initially it increases cardiac output followed by a decrease because it suppresses the vasomotor center. So in the liver decreases glycogen, kidney decreases urine output. Now, ether as an anesthetic, the advantage is it causes CNS depression, excellent muscle relaxant, and causes surgical anesthesia. The disadvantage is why it has been stopped, the usage has been stopped. It is flammable, irritant, irritates the mucous membrane, causes breath holding, and induces nausea and vomiting. Okay, and hence it was stopped. So it irritates these are important. Flammable, irritates mucous membrane, causes increased secretion, leads to breath holding, and induces nausea, vomiting. It is contraindicated in kidney and liver diseases and of course respiratory conditions because it irritates mucous membrane. So basically it's contraindicated in half the things, so really it's not used anymore. Now coming to halothane, this is also not used much, but it was very popular in pediatric anesthesia because of its sweet smell and quick induction. So it was halothane is 2-bromo 2-chloro trifluoroethane, synthesized in 1951, most potent inhalation anesthetic because it is the most potent. The potency depends on the MAC. So it is the most potent inhalation anesthetic because of the low MAC of 0.75. Of course, yeah, it has a low. So MAC determines potency. This has a low MAC and it's more potent. It has a low. It actually does not have a very low blood as compared to the other anesthetic gases. As compared to ether, it has a low blood solubility coefficient. But as compared to other inhalation anesthetics, it is quite higher. However, the induction is relatively rapid. Now, halothane, the chemical and physical properties. It is like I told you, 2-bromo 2-chloro trifluoroethane, volatile, kept in sealed bottles, non-explosive, non-inflammable. It has a pleasant smell, non-irritant. However, to prevent its oxidation, it is kept in brownish color bottles. Okay, that is to prevent oxidation. So brownish bottles. It is light sensitive, so like I said, to prevent oxidation. Corrosive and interaction. The corrosive action can be seen when it interacts with rubber and plastic tubing. Pharmacokinetics, we discussed this, so I will go through it quickly. The potency is basically the minimum potency is related to MAC. MAC is small for potent anesthetics such as halothane and large for less potent agents such as sevoflurane, which is 104. So as you can see, halothane is 0.75, isoflurane is 1.2%, sevoflurane 2%, and desflurane 6%, nitrous oxide 105. Therapeutic uses. Halothane is a potent anesthetic but relatively weak analgesic. Thus, it is usually administered with nitrous oxide because nitrous oxide is an analgesic. Opioids or local anesthetics, potent bronchodilator, relaxes both skeletal and uterine muscles. All inhalation anesthetics relax skeletal and uterine muscles. Can be used in obstetrics when uterine relaxation is indicated. It is not hepatotoxic in children, unlike in adults, because that is an immune-mediated hepatotoxicity which requires exposure, and hence it is said to be not hepatotoxic in children. Immune it's an immune etiology and hence requires repeated exposure. Combined with its pleasant odor, it is suitable for pediatric inhalation induction because of the pleasant odor. However, now sevoflurane is available and is the agent of choice for pediatric induction. I have already gone through this mechanism of action with you all. Now coming to the metabolism of halothane. So it is metabolized in the liver by oxidative pathways and by reductive pathways. It depends on the PO2. So when there's a decreased PO2, it is reductive, and oxidative when the PO2 is adequate. Major metabolites are bromine, chlorine, trifluoroacetic acid, and trifluoroacetyl ethyl amide. Now this is the metabolite which will cause your immune hepatotoxicity. So dosage and administration. Induction dose varies from patient to patient. There is no induction dose as such. The maintenance dose varies from 0.5% to 1.5%. Halothane may be administered with either oxygen or a mixture of oxygen and nitrous oxide. Indications and contraindications. Halothane is indicated for the induction and maintenance of general anesthesia. Contraindication is it is not recommended for obstetrical anesthesia except when you need uterine relaxation. Effects on the respiratory system. So halothane, it causes respiratory depression, that we know. These are inhaled anesthetics, they will cause respiratory depression. Inhibition of salivary and bronchial secretions. It is a bronchodilator, so it protects the airway. It can cause tachypnea, increased respiratory rate, and we discussed the respiratory effects previously, and reduce in tidal volume and alveolar ventilation. It causes the decrease in mucociliary function, which can lead to sputum retention. This is also important. It causes bronchodilation. Hypoxia, acidosis, or apnea may develop during deep anesthesia. Now the CNS effects, of course, like I explained to you all, this is a common to all inhalation anesthetics. At 1 max, more than 0.4 max, lower frequency and high voltage on EEG. There's loss of response to verbal command at Mach awake, that is 0.4. There is a dose dependent increase in the cerebral blood flow and the ICP, that is seen with nitrous oxide 2, a dose dependent increase in cerebral blood flow and ICP. However, nitrous oxide does not increase ICP, and because it does not cause any change in carbon dioxide, so there will be no increase in ICP, but it increases the cerebral blood flow. So halothane increases cerebral blood flow and ICP due to vasodilatation and decrease in the cerebral vascular resistance. But even though there is a decrease, so even though there is a decrease in the cerebral blood flow and there's a decrease in ICP, there is also a decrease in the cerebral, there is no increase in cerebral metabolic oxygen requirements. So basically, when there's a decrease in blood flow, there should be an increase in the cerebral metabolic requirements, but there is no decrease in cerebral metabolic requirements with these inhalation anesthetics. These are common to all the inhalation anesthetics with a few changes. On the cardiovascular system, halothane reduces the blood pressure. It causes bradycardia. Atropine may reverse this bradycardia. So it causes a decrease in cardiac output and as well as contractility. That is a mechanism of halothane. It also causes dilation of the vessels of the skin and skeletal muscles. Like I said, increased blood flow to the skin and skeletal muscles. It may be advantageous in patients with coronary artery disease because of decreased oxygen demand, because it decreases contractility. Arrhythmias are very common, especially when administered with epinephrine. These are all important points. Okay, and how to minimize this? It is triggered during hypoxemia and hypercapnia, so it should be avoided. And avoid concentrations of adrenaline which are higher than 1 in 10,000 units. So there is a dose dependent increase in the mean arterial pressure in healthy patients. There's a decrease in dose dependent decrease in mean arterial. There's a decrease, not increase. There's a decrease in mean arterial pressure because of the decrease in myocardial contractility and cardiac output. All other inhaled anesthetics decrease the BP, not nitrous oxide, by decrease in systemic vascular resistance. Halothane causes decrease in myocardial contractility and cardiac output. There's unchanged heart rate even though there is a fall in BP. This represents depression of the cardiac carotid sinus and drug-induced decreased rate of sinus node depolarization. So it depresses the carotid sinus, the sinus node, AV node, and his Purkinje fibers, right? Decrease in cardiac output. Halothane, isoflurane, desflurane, but not sevoflurane increase the right atrial pressure. Of course, it causes cutaneous vasodilatation. On the gastrointestinal tract, it causes inhibition of gastric motility and causes severe post-operative nausea, vomiting. This is a side effect of halothane. It relaxes uterine muscles, may cause postpartum hemorrhage. Hence, nitrous oxide can be added as it is a constrictor, uterine constrictor. Concentration less than 0.5% is associated with increased blood loss during therapeutic vasodilator. It causes skeletal muscle relaxation. Shivering is another side effect of post-operative shivering is another side effect of halothane. This increases the oxygen requirements which could worsen hypoxemia. Now coming to hepatic dysfunction, halothane acts as a vasoconstrictor on the hepatic circulation. All other inhalation anesthetics act as vasodilators. Okay. So maintenance of hepatic oxygen delivery relative to demand is very important to maintain hepatocyte oxygenation. Hepatocyte hypoxemia leads to hepatic dysfunction, necrosis, and failure, right? So it is very important to maintain the oxygenation to the hepatocyte. So all other inhalation anesthetics except sevoflurane cause vasodilatation. However, they can produce hepatotoxicity with the immune mechanism because they also, like I discussed currently, they also produce those adducts, those neo antigens are produced by these inhalation anesthetics too. So there are two types of dysfunction. In type 1 is basically a self-limited. It is mild. There will be nausea, vomiting, fever. This is because of changes in blood flow. That is basically there is hypoxia because of decreased blood flow. And this is due to results from a reductive metabolism rather than from the oxidative pathway. And it is self-limited and stops post-operatively. It can be seen. Now your type 2, which is rarer, but it is fulminant. It cause esophageal, fever, rash, arthralgia, jaundice, and finally hepatic necrosis seen in 1 to 10,000 to 1 in 30,000 adult patients. Risk factors are female gender, obesity, middle age, and multiple exposure to halothane. It is immune-mediated hepatotoxicity and brought about by IgG antibodies, and it is increased by repeated exposure of the drug. It can result even after years of exposure. Like, since all the other anesthetics can form adducts, the neoantigens, basically it is what I taught you all, the neoantigens, that is the IgG antibodies are directed against the liver microsomal proteins which are located on the hepatocytes. These become they undergo covalent modification because of the oxidative metabolite of halothane, which I told you all about, the triacetyl halide. So because of that metabolite, these microsomal proteins become neoantigens. Basically, they go against the body and they become foreign antigens, neoantigens, and these IgG antibodies are produced against it, leading to hepatic necrosis. So this requires repeated exposure because it is an immune mediated process, right? So it requires repeated exposure. So this repeated exposure is brought about because when anesthesia is administered using halothane. So now suppose halothane has been administered twice and on the third time isoflurane is given. It can produce this fulminant hepatic failure because, like I said, all the other anesthetics other than inhalation agents other than sevoflurane can form these, undergo this oxidative metabolism in the liver. Sevoflurane has no metabolism in the liver. All the rest go undergo this metabolism in the liver, but they cannot produce this necrosis individually. Like if the patient is only taking isoflurane, cannot, because the main route of elimination is by the lungs. The hepatic metabolism is very minimal. But when you give halothane anesthesia first, the liver is already sensitized. So when isoflurane is or sevo or desflurane or enflurane is given, it can sensitize. So basically, a careful anesthetic history of repeated exposure to halothane within 3 months should be elicited, and history of unexplained jaundice or pyrexia after previous exposure of halothane should indicate and should give a red light sign. Main advantages of halothane: its rapid smooth induction, minimal stimulation of salivary and bronchial secretion, bronchodilation, causes muscle relaxation and rapid recovery. Disadvantages are poor analgesia, arrhythmias, post-operative shivering and liver toxicity. Now, enflurane, not very much used. MAC is 1.68. It is a potent cardiovascular depressant. Sweet odor, does not sensitize the heart to catecholamines. Seizures, it produces seizures and hence contraindicated in epileptics and hence not used. And caution in renal failure because the metabolite produced is fluoride can lead to fluoride nephrotoxicity. CNS effects: like all inhalation anesthetics, so slower frequency and higher voltage as dose is increased. However, doses more than 2 MAC can induce seizure. This can be worsened with hyperventilation. There is loss of verbal response at MAC awake. It causes dose-dependent increase in cerebral blood flow and ICP. This raise in ICP can be prevented by hyperventilation, but then this hyperventilation can lead to seizures, and as a result, hyperventilation cannot be initiated to decrease the ICP. There is a decrease in cerebral vascular resistance and a decrease in cerebral metabolic requirements. There is increase, so this raised intracranial pressure can be worsened because it increases the rate of production and decreases the reabsorption of CSF. So this will further cause a raise in ICP. So it is generally not used. Now isoflurane, it is an isomer of enflurane. It is colorless, volatile liquid. It has a pungent odor, stable, no preservative, non-flammable. It is least soluble of the modern inhalation agents. It is not soluble and hence equilibrates more rapidly. Induction is rapid. It is pungent and can, because of the pungency, can cause cough and breath holding. Now coming to the CVS effects, the CNS effects are similar. Now it causes a dose dependent increase in mean arterial pressure because it causes a, this is a decrease again. So it causes a decrease in the BP, basically the mean arterial pressure, because of the decrease in systemic vascular resistance. Halothane causes decrease in cardiac output and contractility, causing decrease in NET. So the decrease in SVR increases skeletal muscle blood flow and causes cutaneous vasodilatation. It increases heart rate. Sevoflurane halothane causes no change in heart rate. Sevoflurane, isoflurane, sevoflurane, desflurane increase heart rate. Sevoflurane increases at concentration more than 1.5 max. Desflurane generally causes no increase in heart rate, right? But sevoflurane known to cause increase in heart rate. So it causes depression of myocardial contractility, vasodilating effect, and potency make isoflurane more cardiostable. So it dilates the coronary arteries, and because of its potency, low MAC, basically, uh, it is a potent agent. 1.2% is a MAC, so it is high potency, vasodilating effect, and decreases the myocardial contractility, and hence it is cardiostable. It is known to cause a coronary steal phenomenon, but not very proven. So coronary steal is basically it from the areas of ischemia due to the vasodilatation. From ischemic areas due to vasodilatation, the blood supply is stolen to non-ischemic areas, worsening the injury in the ischemic area. So a rapid increase in desflurane is associated, a rapid increase in, so basically desflurane when used can cause a rapid increase in, rapid increase in uh, a rapid increase in heart rate and BP is seen when desflurane is suddenly increased. When desflurane is suddenly increased, sudden increase in desflurane can cause increase in BP and heart rate. This is attributed because of increase in norepinephrine, plasma norepinephrine levels. So norepinephrine levels are increased when there is a sudden increase in desflurane. So if you increase the concentration of desflurane like from 6 mac to suddenly to 8 mac, there will be an increase in heart rate and BP. This is because of the increased release of norepinephrine. This is seen with desflurane. Now mechanisms of circulatory effect are basically inhibition of CNS, the sympathetic activity. Then direct myocardial cardiac depression, decreased formation of adenosine, ganglion blockade, decreased baroreceptor reflex, decreased baroreceptor reflex, decreased catecholamine release, and decreased calcium ion influx. Okay, these are various cause mechanisms of the circulatory effects. CNS effects are similar. It, of course, what is noteworthy is isoflurane has anticonvulsant activity, and the rest are all similar, and it is offers the most cerebral protection. Advantages are rapid induction and recovery, little risk of hepatic or renal toxicity, cardiovascular stability, muscle relaxation. Disadvantages are its pungent odor and coronary vasodilatation leading to coronary steal. Now, sevoflurane, it is a much newer drug. It is non-flammable, pleasant smell, MAC of around 2%, stable, low blood gas partition coefficient, faster equilibrium, not soluble in blood, non-irritant, so fastest for pediatric inductions. On the respiratory system, as already discussed, the common effects, it is non-irritant, depression. CVS same as isoflurane, slightly low effect. Isoflurane is the most cardiostable. Same as halothane, and effects on the CNS all similar. Muscle relaxation also, like other inhalation anesthetics. The advantages are it is well tolerated because it is non-irritant and sweet even at high concentration, making it the agent of choice for inhalation induction. Rapid induction and recovery because of the low blood gas coefficient. Does not sensitize the myocardium to catecholamines like halothane. Only halothane sensitizes the cardiac to catecholamines causing arrhythmias, and it does not result in carbon monoxide production with dry soda lime like we discussed. And it can, all inhalation agents can, but sevoflurane to a lesser extent. The disadvantages are it is less potent because of the higher MAC. It can interact with the carbon dioxide, desiccated carbon dioxide absorbents in the presence of soda lime, especially with sodium hydroxide, potassium hydroxide. With berry lime, it caused fires and hence berry lime was stopped. It can lead to the formation of compound A, what I revised with you all, which is toxic to the brain, liver, and kidneys. That produces the vinyl nephrotoxicity is produced by this compound A. It is highly nephrotoxic in rats. However, the concentrations that are used in anesthesia do not produce enough compound A to cause nephrotoxicity, as that is why compound A production is seen more with low flows. As a result, it is always advisable to keep the fresh gas flows to more to a, to a minimum of more than 1 liter. Ideally 2, but more than 1 liter for sure. The fresh gas flow should be kept to prevent this compound A formation. About 5% is metabolized, and there's elevation of serum fluoride. So compound A cannot produce, sevoflurane cannot produce hepatotoxicity because it does not contain the vinyl component. It does not undergo degradation to not the halide component, right? So it does not undergo oxidative metabolism. That it does not form that trifluoroacetyl halide metabolite. As a result, it does not sensitize the liver and does not cause hepatotoxicity. However, it is metabolized to fluoride, which can cause fluoride nephrotoxicity. Okay. Post-operative agitation is more common in children. So, sevoflurane causes post-operative agitation. So, fluoride-induced hepatotoxicity. It causes polyuria, hyponatremia, hyperosmolarity, increased plasma creatinine. This is seen more, actually it was seen more with methoxyflurane, and the toxicity generally occurred when the concentration of fluoride ions was more than 80 micromole per minute. So it was suggested that 50 micromole will be the cutoff beyond which it can be said that toxicity will occur. But however, other fluoride and other inhaled anesthetics, all the rest produce this fluoride ion except halothane, and but this does not cause nephrotoxicity. That is because the primary route of elimination is by the lungs, and so even if they have that 50 micromole is produced, it is still not seen to produce nephrotoxicity. So that reasoning was discarded where the cutoff was 50 micromole per minute, right? So it was only seen with methoxyflurane because methoxyflurane, like halothane, undergoes predominant metabolism. So fluorane undergoes metabolism more by the kidney, produces nephrotoxicity. Halothane produces hepatotoxicity. So enzyme induction, obesity, pre-existing renal dysfunction, seen with enflurane, nephrotoxicity. So desflurane, the last inhalation anesthetic, MAC is 6. It is delivered through a special vaporizer, temperature control. It is a popular anesthetic for daycare surgery, important. Induction and recovery is fast. As a result, daycare surgery. Cognitive and motor impairment are short-lived. As a result, daycare surgery. It irritates the air passage. It can cause bronchoconstriction. That is a negative point. So this is the comparative pharmacology of the inhaled anesthetics. The blood gas coefficient, oil gas coefficient, the features, and the various notes: halothane causing hepatitis, hypothermia, arrhythmia, and fluorine causing seizures and hypothermia, isoflurane ideally used, desflurane causing cough, nitrous oxide causing anemia. So the thing with nitrous oxide is it inhibits, it cannot be used in pregnant ladies because it inhibits that vitamin, it inhibits B12, it inhibits the enzymes that require B12, like because it methionine synthase and thymidylate synthase, because it inhibits basically neuron generation and DNA synthesis. So in the fetus, it can cause a lot of congenital anomalies. So in pregnancy, nitrous oxide should not be used. Ideally, it can lead to a lot of fetal. So that is on prolonged exposure, like basically for the anesthesiologist, nitrous oxide should be avoided because it leads to, even so until the fetus is delivered, we do not turn on nitrous oxide because it can lead to a lot of side effects in the fetus. Okay guys, that was my class for today. It was a long class, but anyways, hope you all understood because it was a good repetition. So hopefully you all have understood. So guys, please use my code SASHA like I said to avail your 10% discounts, and I will see you all again tomorrow morning for a short quiz session. Good night guys, have a good evening.